Hi everyone, welcome to today's webinar. We are getting all set up here and I can see people joining as we speak, but I wanted to get started right on time. I'm also going to turn on my webcam since we're all social distancing, but I am actually here. Hello. All right, so just getting all of this set to go. So we certainly could talk about this topic for a lot longer than an hour, but I want to respect everyone's time. We will end a few minutes early if you're going to session or going to another meeting. I want to be very respectful of everybody's time. And what I want to do is first go over just some basic kind of technology, housekeeping, how to navigate GoToWebinar from the attendee side of things to make this as smooth as possible if you want to participate, have questions, anything comes up. And then I do want to spend a few minutes at the end going over a little bit about Cascade Centers, EAP, and some information about that too that may help just in general as a provider, but also as it relates to this topic. All right, so let me go to a few pieces of housekeeping here, always the exciting part. Typically, this is a pretty, self-explanatory process, but I still think it's helpful to get an idea of what we're looking at. So on your end, you'll see just this little panel on the side of your screen. There's a few things that I wanted to go over. When you see the little gray line that says handouts on yours, obviously it's just an example, you should have two handouts. If you click on that little white arrow, you'll see two attachments. One is the PDF of today's slide deck, if you have any interest in saving that as a resource. And then there is also, and this is a very helpful, important thing to remember, there's a tech help slide for webinar questions, troubleshooting. It has just about everything you could possibly need on there. So if you're having any technological issues, please start there. We have, I think, over 100 people signed up today. I do my best if people are having tech problems. There's only so much I can do while I'm teaching, and I don't want to interrupt that process too much, which is why we want to make it as easily accessible and solutions at your fingertips as needed. So that handouts attachment, and someone just said that they can't hear anything. So hopefully people can still see my subtitles, but if you just joined, please go to the handout section and go to the webinar tech help PDF and look at that, and that can help you with all of the audio concerns you may have. Usually that's the issue people have. So go to that tech help slide. It has the number to call in if you need to, the access code, troubleshooting options, etc. All right, so the other thing is we're going to do a live poll question. Those are completely anonymous. You obviously don't have to participate in the poll question if you don't need to, but no one knows who answered what, so it is a completely anonymous poll. And we'll do one of those near the beginning, so just a heads up on that. Let's see, questions as well. So how do you communicate with me if you have questions? You will see here on the screenshot as well, there's that arrow drop down that says questions, simple enough, and you would type that in. So the main thing, and it mentions this on this slide as well, when you type in a question into the questions box, I'm the only one who sees that question. So if it's related to content, and we'll try to have some time at the end for Q&A as time allows, or if you have a question during the presentation, if I have time to address it, I will. Type that into the questions box. So if you notice me kind of glancing over, that's just me keeping an eye on questions that may be coming through. And I maintain anonymity there. So when I do answer a question, I'm not going to say who asked it. I'm just going to say someone asked about, and then I'll summarize that person's question. So if there's any concern about, anonymity, we default to that. You'll get a certificate at the end of this. All attendees will get sent a certificate from our training coordinator, so that will be sent to you ASAP, since I'm sure that's part of this. So you will get a certificate of completion. And let me see if there's anything else we needed to go over. Most of that is taken care of. So again, for those of you who have joined, if you're having any audio issues or tech issues, please look at that PDF attachment of webinar tech support under handouts. That should answer everything you need to know. All right, so I'm sure some people are going to continue, joining today's training as it goes. I believe that we will also be providing this free on our YouTube page after today's event. You know, that obviously watching it later isn't going to, you wouldn't receive a certificate from watching it on YouTube, but it at least is also a way to access it later if you wanted to see the live presentation of it, and other than just having the PDF of the slides, which attendees have access to download right now. Okay, so let's get into it. Hopefully there aren't any major issues with technology or anything. I'm seeing what you're seeing, and it looks like we're good to go on that. All right, I always like to keep an eye on things. So what I wanted to do before we get into the content is, I think, you know, especially, and actually I'm just noticing this right now, this is one thing I forgot to mention, because of the number of people attending today, although you have a feature on your end that is a hand raise feature, the challenge is that audience members are automatically muted. And when someone clicks that hand raise feature, I can't see who raised their hand or why. And so the best way to communicate with me, if you have questions or anything, please type that into the questions box, because the hand raise feature is going to be harder to access. So if anyone, again, has any issues with audio, please look at that webinar tech help. If someone can hear my audio, can you type that into the questions box and just say, yes, I can hear you? I like to just double check that which end things are happening on. So hopefully, okay, great. If you haven't typed it in yet, then don't worry. I got confirmation that people can hear my audio. So if you cannot hear my audio, it is on your end, but there are lots of different possibilities for that. It could just be settings. It could be a number of things. It's very common. Please look at the audio tech help handout. Okay, moving on. Thank you for being on this journey with me on the technological side. So what I wanted to go over is my background, because anytime we do a training, I like to get some context of who is doing that training. And as all of you being our wonderful affiliate providers, you also may have heard my voice on your voicemail when I left you a voicemail with a referral. This is me, hello. And as you can see, so I am from Portland, and I know that in this day and age, sometimes that's more surprising than someone in Portland who's not from Portland, but I am born and raised Portland, Oregon. I'm back here now. I've lived in many other states in the US, but I've come back to Portland, you know, similar to the salmon going the whole route here. So my master's degree I got in Philadelphia, and that was in counseling psychology with a focus on trauma psychology, trauma and recovery treatment. And I worked after that as a board member and a facilitator at the Peace Center, which is a nonprofit in Langhorne. Langhorne was about 30 minutes outside of Philly. And a lot of what we did was interventions in schools. And most of that was in middle schools and elementary schools. Some of it was preventative interventions. We would teach young elementary school classrooms on how to communicate effectively, how to manage emotions. But we would also I also did a lot of consultations with school administrators on how to be more inclusive, how to try to reduce bullying. And so we really worked with students and with the administration simultaneously. And some of that, again, was preventative. Some of that was something happened and we need to consult on how to handle this. Definitely interesting work. And then I've worked in community mental health for many years, running groups, seeing individuals, couples, families. I've been at Cascade Center since 2014. I'm also a certified alcohol and drug counselor. And during the Oregon Promise rollout of PCC, which essentially that was a grant where if people signed up for community college right after they graduated high school, they could get 2 years free community college. So they needed more faculty, understandably. So I was adjunct faculty part-time during that time, assisting with that. So at Cascade Centers, I started as a full-time counselor, and then I realized I still loved teaching and training more than anything. And so I'm now the head of the training department and organizational development department at Cascade. So I create content, I do trainings, but I still provide immediate telephone counseling as needed. So I still have, you know, a component of what I do is direct clinical work. So there's a mixture of things, but I wanted to at least give some background on that, kind of tell you a little bit about me before we get into context. Okay, so I do want to get into what we are going to be discussing today. So this is, some of the first few slides are definition heavy because I want to spend the most of the training around, so what does that look like in real time? And yes, that second bullet point is very much motivational interviewing, but I think so much of that is that self-awareness and that ability to practice self-awareness and take a look at ourselves comes from that ability to see that, and I think it can be very helpful through that motivational interviewing lens. So for example, how would you know if you were suddenly had a more culturally competent practice? Like, how would that actually look if it was suddenly more culturally competent tomorrow? What would that look like? And of course, I'll go into some examples later on, but I think just kind of seeing a definition here, and that is the American College Counseling Association. That's underneath the umbrella of the ACA. If anyone's wondering what that acronym is, I didn't accidentally put an extra letter in there, but it's under the umbrella of the ACA. So that's their definition of cultural competence. I still think it's helpful to just have an understanding, a working definition of what that is. I'm not here to read slides, so I'm not going to read whole paragraphs. You obviously can see this yourself and have access to these slides afterwards. What I really want to do is have more of a conversation around this. What does this look like to be proactively self-aware around cultural competence and awareness? And there are steps that we can take. There's that difference between I'm not culturally incompetent and I'm just sort of say that versus I'm taking actionable steps to be more culturally competent, to be more self-aware, to address implicit bias. There are steps we are taking. It requires work. And so this is, I think as many of us know, it's not I've suddenly hit cultural competence, now I'm done. It's ongoing learning, and we'll talk about privilege here in a moment, but it's that noticing that realization, I think for a lot of people is, if it's something you've never had to think about, it probably means it's an area that you're privileged in. So all of us have privilege. We'll talk about privilege, intersectionality, but this is really about how do I take the time to put in the work to change behaviors, learn more about my bias. So what I wanted to do is just do a live poll, and we have almost 70 people right now, so that makes the poll more interesting. If you joined a little bit later, these polls are completely anonymous. No one will have any idea who answered what, but they're also obviously optional. So I'm going to launch this poll really quickly, and just your classic Likert scale, if you will, but I'm going to give people a moment just to kind of consider how they would answer that. And I think it helps to just give ourselves that level of self-awareness, and we'll obviously see where the general outcome is. All right, so we've got about 60% of you voted. Now we're almost up to 70%. I'll give it about 10 more seconds, just if people are still thinking. Votes are still coming in, so I don't want to rush anyone, but I am sensitive to time as well. So I'll give it about 5 more seconds here. All right, so we had 80% of you have voted, and let me just share the results real quick. Okay, so what I want to, again, what's helpful about this is not only the self-awareness piece of having to answer that, but also seeing where other people are at, and just kind of giving ourselves a gauge, and how would I, measure this? How do I see this with, my peers, other providers? And it's across the board. I'm not surprised by that either. So just kind of a starting point to see where we are. And before we go into what do we do? All right, there we go. Make sure I got that off the screen. So I wanted to provide a few other examples. This is something, I've done a lot of trainings on DEI for employees for our groups, and for leadership for the companies we serve. And a lot of this is almost always I get so many questions around these definitions. There's a lot of uncertainty around how these definitions are differentiated. Cisgender is something that we are hearing more, hearing that word, and I have a lot of people ask, what does that mean? So I wanted to, again, as I told you, some of these initial slides are definition heavy, but this is so much about education. How do I educate myself? And this is ongoing learning, and we have to take the time to educate ourselves. And I share this slide just because of the sheer number of questions I get around how these are differentiated. And so really kind of understanding that, taking time to consider that. And as we talk about privilege here in a moment, sort of understanding how that intersectionality falls into place. So this is, kind of going over the difference here between gender identity, cisgender, transgender, sexual orientation, gender expression. And again, sometimes there's a confusion around gender identity versus sexual orientation. So if you have any questions about this, as we go through here, again, I don't want to read every slide, and I really want to get into what to do next, but I still want to provide some of these definitions up front so you had them accessible to you even as a resource after the training as well, because again, you can download the PDF of today's slides if you'd like to do that. And then a few other ones. So BIPOC is Black, Indigenous, and People of Color. So that's an acronym again that sometimes people aren't sure what that stands for. I think for many of us, we have an understanding of what ethnicity refers to, but I still think it helps to have a working definition. But I want to talk a little bit about privilege and intersectionality, and then I'll give some examples of privilege. So one of the things that I think comes up a lot is when individuals who have privilege in one or more areas hear that they are privileged. Sometimes, again, I don't want to generalize, there's a sense of, I can't be privileged because I'm not economically privileged. And I think sometimes we really tend to say that economic privilege is sort of like the one and only definition of that. And there's sometimes that pushback of, I'm not privileged because I'm not economically privileged. Economic privilege is absolutely a component of being privileged, but only one component. There's many areas of that. So I wanted to really clarify that when we understand privilege. This will be very clear on the next slide when I give some real world examples of how privilege shows up in ways that are not necessarily for economic reasons, but that is something I see come up a lot when there is discomfort. The other thing that I hear a lot is when someone is told they have privilege, say as it relates to their skin tone, their race, they'll equate being told that they're privileged with being told that they are racist. And those are also different. And so we'll see some pushback on that of feeling defensive about being identified as having privilege. And that's our job as individuals to learn how to not be defensive and receive that information and understand how our privilege, based on all of our demographic makeup, impacts ourselves and how we interact with clients and the world. So a lot of this, again, is reminding ourselves, how do I react if I am told or informed that I have privilege in one or more areas? And then intersectionality really speaks to that, because a person can have privilege based on their sexual orientation and not have privilege based on their race, or vice versa. So there's all sorts of intersectionality as it relates to the different demographics that make up who a person is, and which of those are privileged and which of those are not. So those are some things I think are helpful to understand as it relates to how we understand ourselves, our clients, those who we serve in our practice, and how we interact with them. All right, so what are some examples of privilege? This is obviously not an exhaustive list, but I think it's helpful to just think about this in some real world examples. So in this case, I am going to read these. So my promise of never reading slides, I'm going to break that promise briefly. So you can turn on the TV or read the news and see your demographic widely represented. You can be sure that your children will be given curricular materials that are primarily from your demographics point of view. You've never had to consider whether a building or facility that you had to go to is wheelchair accessible or not. You're never asked to speak for all people of your demographic group. Emojis, band-aids, etc. are always based on, or at least available in your skin tone. And you've never had to worry about that your physician will shame or misdiagnose you due to your weight. And medical bias is certainly not only related to weight, it's related to all non-privileged demographics. So I do want to just have a caveat there that I totally understand that, but just using that as an example as it relates to weight discrimination. So these are just some things, and I think, again, understanding our privilege is about that willingness to be self-aware. And if you looked through that list as I was reading that off, it's like, I've never had to think about that. You're right, I haven't had to think about that. That doesn't make you a bad person. It's about, how do I push through that privilege of not ever having to think about that before? And how do I educate myself on this? And how do I think about that as it relates to my actual practice? And it's really interesting now, as clinicians, being probably for many of us exclusively telehealth, and how does that impact this in terms of people's access to high-speed internet, computers, webcams? You know, there's all sorts of things happening with COVID specifically, and how is that going to impact mental health treatment, even, and a lot of medical treatment even beyond COVID? Because I think, as all of us know, there's a lot of research around attendance goes up when it's telehealth. There's not the issue of trying to travel, find childcare if needed, all of these different things, find someone to drive someone or ride public transit. So I think for many people, there may be continue to be more telehealth options in mental health, et cetera. And so thinking about how that impacts us as being inclusive and equitable, and trying to, you know, see that through not only the in-person setup of, you know, that in-person office, but telehealth as well. So again, I just think it's really important for us to consider how this shows up. And if we're not thinking about this, it's just, how do I push through the discomfort of realizing I have privilege in one or more area? And then, so one thing that I think can be really helpful here, and I added the link on here, obviously you can just copy and paste that off of the PDF if you want to download the set of slides, is this implicit bias test. And one thing I like about this, if you go to that link, when you go to that link initially, you'll have a first page that's like, yes, I want to take these tests. And then you click on that at the bottom, and it'll take you to a list of, I think, at least 20 different implicit bias tests based on different things like race, sexual orientation. There's all sorts of different ones. And it helps assess you where you're at on your level of implicit bias around those different demographics. So if you want some real-time strategy, takeaway suggestion, what can I do next? That is an easy thing to do, to check in on that, because there are many different areas that we're privileged in. Again, intersectionality. So we may think, you know, I'm super aware and knowledgeable about, you know, racism, sexism, but are you as aware and knowledgeable about how people are discriminated against on weight, on age? There's all these different things. So it's really important to practice that self-awareness, and that is one resource to do that. And then there's that systematic versus systemic oppression. And systematic, I think, is where we, thinking about it from a clinical perspective in our paperwork, in our informed consent documentation, you know, we'll say everything in here is, you know, equitable in terms of who we serve, and the language that I use is inclusive. And so a lot of times I see that, and then in the day-to-day interactions, the implicit bias comes in. So on paper, or in terms of the board's, you know, laws that we fall within of ethical treatment, that all, you know, is written down and is clearly, you know, saying this is an ethical practice, this doesn't discriminate on paper. And then thinking, how does that show up? So that systemic level is harder to measure. It's harder to hold people accountable for sometimes, because a lot of times it's really implicit. So it's that unconscious attitude, stereotypes we have about other people. Sometimes we know that it's there, but we're just kind of trying to ignore it or pretending it's not there. Other times we truly don't realize that we have that implicit bias, which it can be helpful, again, to do a test like this, to even just kind of pay attention to that, learn more about that, consider how that may be coming up for you. And the other thing too is that as human beings, we have, and I know I'm talking to clinicians, automatic thoughts. And it's not that we are going to forever eliminate every automatic thought or belief that pops into our head. It's about not instantly believing it. And all of us understand CBT and thought stopping and taking a moment to step back and think, where did that thought just come from? Where did that assumption just come from? And this is where that implicit bias comes into play. And so the more that we can take those active steps, pay attention to that, consider how that shows up. And again, this is one way that you can start that process on your own time. I would encourage you to look at that link and take some time to consider what may be showing up for you in terms of that implicit bias piece. So if we're thinking about this as it shows up in the clinical space, so if I'm working, say, with someone one-on-one, for example, there's different levels of injustice. And these are, a philosopher, Miranda Fricker, she's a philosopher, she came up with these two terms, and philosophers love using huge words. It's kind of how a lot of clinicians, we all love acronyms, but the concept is fairly simple. So there's testimonial and there's hermeneutical interpersonal injustice, lots of big words. So testimonial, when a person is not considered credible or trustworthy due to the prejudice of the people listening to them. And then hermeneutical is when someone's personal or social experiences are hidden and are denied from communal understanding. And, these are sort of like a Venn diagram. There's a lot of crossover in terms of what's happening regarding the injustice, but this is really that falls within more of that systemic injustice. It's not on paper. This isn't relating to being written in law. It's about the day-to-day interactions. And just like on that slide around privilege, this shows up when people seek medical help and are not considered credible or trustworthy, or not taken as seriously. There are more research studies than any of us can count on how that shows up with gender, race, etc., of weight, age, all sorts of things in terms of not being taken seriously, being misdiagnosed. And so this can also come up in therapy, in the mental health treatment. So being very aware of that. And I'm going to talk about microaggressions here in a moment. And, it's interesting now, I communicate with a lot of providers in the field, probably many of you, and nationwide. And, a lot of times it's even the language that we use around talking about clients or consulting about clients is just being aware of that. And I'll talk more about that later. But there's also that direct interpersonal interaction we have with clients and really focusing on, how am I receiving the information they're telling me based on my implicit bias? Because it goes back to classic DBT, dialectics, two things can be true at the same time. I can have two people tell me the exact same thing, and one of them falls within a privileged group or individual who I don't have implicit bias towards, one does, and I'm receiving that information from them very different based on that lens. I'm either taking them more seriously, I am, so there's all of these, dynamics happening that we usually don't realize are happening. A lot of times that is that implicit level, and it's just built into the way that we communicate, but taking, very intentional steps to pay attention to that. What are your automatic assumptions when someone talks to you about an issue? What are the ways that you respond, etc.? All right, let's see here. All right, so talking about microaggressions a little bit. This was, there's so many different ways this can show up. Again, I'm not going to read that entire definition of it. Most of us are familiar with that term at this point, but I wanted to give you a couple of real world examples. And one is kind of on a systemic, larger scale, and one is a direct interaction with someone. So I was talking about microaggressions with a group of employees at one of the companies we work with, since again, we do a lot of DEI training just for employees, for people who have EAP. And way back in the day when I was doing one of the trainings in person, when I was talking about microaggressions, one of the attendees, she said, as I'm hearing about this and understanding the definition of microaggressions, I think I just experienced this the other day. And she was willing to share her example to the group. And she said, I'm a veteran and I have a sticker on my car, on, bumper sticker. And I parked at the grocery store, got out, and was just walking into the grocery store, and a man walked past me and said, "Thank your husband for his service." So that is a verbal microaggression. And I think the reason I use that as a common example is because sometimes we think microaggressions are only intentionally trying to hurt someone. And they are almost always unintentional, or we don't realize we're doing them, which makes it incredibly difficult for the person on the receiving end to know how to interrupt. Because for her, and she said this, she was like, by the time I kind of processed what happened, he was already halfway across the parking lot, just continuing walking to his car. Do I run after him and correct him? How do I interrupt that? And I'm left feeling offended, and uncomfortable by that. But he went out of his way to do something nice. And so, and I'm not in any way justifying that, but the reason I'm saying that is that it's sometimes hard for people to know how to interrupt that or to say something. And that is even difficult when there isn't a power dynamic happening. So as a clinician, there's already a power dynamic being a clinician and their client. It is incredibly difficult, and I think we know this, for a client to call out their clinician in any way. It's hard for most people, regardless of who says it, but especially if there's a power dynamic there. And so I've had clinicians say over the years, well, the client never said anything to me that they were uncomfortable about the setup. The client never said anything to me that they needed XYZ. And it's like, yeah, a lot of times they're not going to. They're uncomfortable. There's a power dynamic there. You know, and I think all of us know this, but it's catching ourselves if we fall into, they should just tell me if they wanted me to say something different. So this is asking more questions, you know, asking what someone's preferred pronoun is, for example, instead of assuming. So having that open dialogue, and then also being very thoughtful about the language that we use, changing that language. Oh, someone's asking what DEI stands for, diversity, equity, and inclusion. Thank you, great question. There's some other questions on here. I'm not ignoring you, but I will have some time at the end for Q&A. So it's really about, how do I pay attention to this? Another example of paying attention to language. When we do intakes for people calling in the EAP asking for services, we always make sure to train people on phones who are answering phones. If someone calls and says, my name's Jane Doe, and I'd like to set up marriage counseling, what will happen is someone will say, oh, what's your husband's name? That is another microaggression. It's in no way meant to be harmful. It's not meant to be offensive. It's just an automatic assumption about someone's sexual orientation. And so small things like that. You know, a lot of this shows up if someone is talking about how, you know, if they're getting married or if they're having a kid, the first thing is like, oh, is it a boy or a girl? Even that question really implies a gender dichotomy, that there's only two genders. And why does it matter? You know, so a lot of times just the questions we ask, we're trying to join with the client, we're trying to improve relationship, but in the process, those microaggressions and assumptions can come through. So being very thoughtful of that language that we use. And the other thing too is some verbal examples, and I think all of us, you know, in counselor training and beyond, is just being very thoughtful of the language we use to talk about clients that we're working with. Resistant, dramatic, just being aware of those adjectives that we're using to describe others. And I'm going to talk about person-centered language in a moment that goes into that in more detail. But it's those, you know, kind of nonverbal microaggressions and then the verbal ones. So nonverbal examples, office accessibility, and kind of like I'd mentioned earlier, that could be, is there a wheelchair ramp? What is the, you know, how close is it? And I know there's not always 100% control over this, but how close is it to public transit? You know, there's different dynamics in terms of accessibility. And then just being thoughtful on the decor that we use, and, you know, how are the seating options? Is it equitable and inclusive seating? The personal information we choose to show, like everything, and all of us know this, is that clients are going to see everything in our office, and every single thing we add, item we add, every aspect of that, it sends a message. And so just being very thoughtful of that. It may not even cross our mind to have a certain book or a picture on our shelf, but just being, or the furniture we're using, the accessibility. So there's really the setup in terms of, how does this actually create a safe and equitable space? And it's also, you know, if someone's seeking in-person counseling, and this comes up a lot when we talk about organizational DEI at companies, is that companies will say, you know, because there's equality and equity. So equality is, all of my, say for a clinician, all of my forms are digital, you can fill it out all online, and it's all, you know, equally accessible to everyone. What if someone doesn't have internet where they live, or doesn't have access to a computer? Filling out those types of personal documents is a little bit difficult to do at a public library. And so equitable practice would be, I have them hard copies if needed, that I can either mail to you, or you can come and pick up, or digital. So that's equitable. It's like we're meeting people where they're at. So really thinking about not only physical accessibility, but accessibility to documentation. There's also understanding plain language. So plain language was part of the law within the government that was updated during the ACA. And at that time, there was laws put into place for government agencies that all of their documentation sent to clients for any medical information or medical reasons had to fall within the legal definition of plain language. And at the end of this slide deck, I'm going to give you a link to the government's link to plain language, because a lot of that is that everything written in plain language needs to be at a 5th grade reading level. It has to be accessible. It has to be easily understood the first time it is read through. And that can be both in informed consent documents, any type of document you use with clients. It also could be whether you're emailing with them, etc. So that's another thing that I think helps with being inclusive and equitable, is using plain language. So these are just some examples kind of consider in terms of the real-time implication to, you know, what that looks like to be more inclusive. The other example I was going to tell you about for microaggressions before we move on is, I mentioned earlier that I used to work for a nonprofit over in Philly, and we did a lot of work in schools. And a lot of what I did is talk to administrators at schools saying, we want to be super supportive, we want to be super inclusive, and I truly believed them. And these were wonderful long-term administrators who cared deeply for their students and what was best for them and wanted to make it a safe space. And one of the vice principals, I was sitting down a meeting with her, and she was, you know, trying to figure out a time that we could come in and talk to some of the students, do some different interventions. And she was like, you know, we're really trying to have this be more of a collaborative space where students can support each other. And so we're not going to be able to have your team come in on Friday because we're already doing a student fun day on Friday. And we're having all the girls in one gym getting their hair and makeup done and all the boys in the other gym playing laser tag. So that, again, is an example of these nonverbal microaggressions. And what I think it demonstrates is, even during a time of, we're bringing in a nonprofit focused on DEI and anti-bullying, we want to improve a safe space, and not even realizing, and there's no judgment here, not even realizing how toxic that activity, Friday activity, was. And so that's where the conversation went from there. So it's really, I think, you know, when we are trying to be inclusive, the language we're using, we're trying to, again, join with clients, it's really paying attention to what our implicit bias, our microaggressions might be. There's just so many examples of that. And I wanted to share some of those because both of those examples, again, were people intentionally trying to be inclusive, supportive, and that implicit bias just shows up and really is very toxic. So when we're thinking about trauma-informed care, and probably most of us are familiar with SAMHSA's website. It's a very long acronym. I'll give you a link to their website at the end here, where it has an entire, extremely thorough, full PDF on trauma-informed care. But trauma-informed care, or TIC, and this is seeing it through a more organizational lens. And Sandra Bloom, Dr. Sandra Bloom, she's a psychiatrist from the East Coast, and she really talked about sanctuary within mental health. And I think that sort of turned into understanding things under trauma-informed care. And one of these main components, and she talks about this as well, is instead of what's wrong with you, it's asking what happened to you, and really shifting the way that we work with clients that's more equitable, that's more trauma-informed. I'm seeing a few other questions come through. Don't worry, I'm not ignoring you. So just kind of understanding, if I were to think, how are we more trauma-informed, or how am I more trauma-informed in this organization, what would that look like? And I think someone may have raised their hand. The challenge right now, we have so many people in today's webinar that the hand raise button isn't effective, because I'm not going to know who raised their hand or why. So if you do have a question, just type that into the questions box. So what are some things that you can do if you want to be more trauma-informed in private practice, or in group practice, or any type of organization, really? We do a lot of trauma-informed care trainings for whole organizations as well. So what are some pillars of trauma-informed care? Safety, and all of us clinicians know there's many definitions of safety. It's not just physical, but all levels of safety. Trustworthiness and transparency, this again shows up a lot, not only in that plain language and informed consent, in communication with clients, collaboration and mutuality, and this really goes in line with, for many of us, when we talk about our objectives, our values as a counselor, I think this shows up, but it's thinking, how does that actually show up day to day? Cultural competency, empowerment, voice, and choice. So what are some things that you could do in practice? A lot of this is about how, if I have my own website, some clinicians do, some don't, what images are on my website? What language do I use on my website? And again, if there's a picture of myself, what is that picture all including? When I talk about myself, how am I doing that? All of these different dynamics. What is the whole picture if someone were to click on my website? And is that inclusive? And it's also, this goes back to, instead of saying, yeah, my website has my information, I'm an equitable and inclusive clinician, actually advertise about that. But the piece here is, and we talk to a lot of organizations about this, putting a poster on the wall saying we're equitable and inclusive is different than actually being. So being very thoughtful about that. If we are saying we're trauma informed, if we are saying we're an equitable provider, then we need to know how we're measuring that. We need to be, again, as with anything else, as an ethical therapist, continuing education, educating ourselves, peer supervision, etc. If I'm saying I'm this way, I need to be working towards always making sure that I am that way. We also are not perfect. If we make a mistake, ask for clarification. I'll talk about that a little bit. The other thing with trauma-informed care is train both clinical and non-clinical staff on how to be equitable and trauma-informed. Some of you may have a receptionist or a call center that takes calls for you, have other staff, billing departments, so you may or may not fall into that. But we see this all the time, whether we're working in larger organizations, hospitals, community mental health. Every single person, whether it's, there are people on staff in any level of the organization, any role, how is everyone trauma informed? And that's really important, because the receptionist may be the very first person they talk to. And if they're using microaggressions, if they're not aware of implicit bias, if they're not trained on that, that's their first point of contact that demonstrates what that organization or what that clinician's practice, is representing. So being very thoughtful on the training that we do for anyone on our team, regardless of whether they're clinical staff or not. And we've talked about some of these already. There's, you can find different trauma screening tools. SAMHSA has a ton of resources. I'll show you some other resources at the end. And the rest of these, again, I think we know a lot of this as clinicians on these bullet points, but some of these I just want to spend a little bit of extra time on. So quickly with this person-centered language, it kind of goes back a little bit to that microaggression, is how to create a safe space is a lot of the language that we use. And I think the biggest piece here that I wanted to touch on is this bottom bullet point. Because for many of us, it's interesting because this would come up when we would train in DEI at organizations. I'd hear someone say, okay, well, I'll just make sure not to say that joke around these coworkers. I'd be like, that's not the point, And when I worked in community mental health, or when, in many organizations I worked in, a lot of creating a sanctuary, creating trauma-informed care is that it doesn't matter if the client is around or not, it's still using person-centered, equitable, respectful communication. And whether you're in private practice, group practice, I think for many clinicians, there's ideally some level of peer supervision, peer consultation, because all of us are always learning and needing to learn and can't just exist only in a bubble. It's very helpful to have that peer supervision on some level, regardless of how long we've been practicing. And what sometimes shows up is in that, kind of no clients around discussing clients, our inclusive language falls by the wayside. I've seen this happen in community mental health. A lot of that's due to burnout. But it can happen in peer supervision with people in private practice as well. And that goes back to some of that earlier language I talked about, resistant client, dramatic client, kind of either making jokes about clients, talking about them a certain way. If the language we use about someone, regardless of whether they're there or not, directly correlates with how we feel about them. And so the language that we use is always so important to be aware of. So I would say that, a really big piece of this is paying attention to that. And the proactive piece that goes beyond, I don't use microaggressions. I'm very thoughtful of it. That's all wonderful. But if you are talking to other counselors or if you are in peer supervision, have you practiced calling out effectively and respectfully, but still calling out others if they are using microaggressions, if they are using problematic language? That's that next step. Instead of just only working on ourselves, which of course is critical, how do I also interrupt this and feel comfortable and confident interrupting this if I see this within my peers? So it's that both level of changing our behavior and addressing things that we see around us. Okay, I know there's so much to talk about and I want to be very mindful of people's time. I don't want to go past like 5 till. So I have a couple more slides and then we'll talk quickly about the EAP. And then I do want to have a few Q&A sessions, minutes for that. So these again are just simple kind of reminders about basic communication. A lot of this comes up, when we're talking about DEI and we're talking about equity and inclusion, about implicit bias, assumptions we're making. Sometimes what I see happen is we're asking a person from a demographic to educate us. There's a difference between asking someone what's your preferred pronoun and asking someone to educate you all about a certain area of DEI. So that's our job, to educate ourselves, reading research articles, watching documentaries, reading, evidence-based practice. It's our job to continue to educate ourselves. How do we receive feedback? Because so much of this is not only paying attention to making sure whenever possible, at all times possible, not using microaggressions. It's also, as we know, just as important to know how to receive feedback, because we aren't perfect, we're going to make mistakes. And although with a client-therapist dynamic, oftentimes it's difficult for clients because of that power dynamic to call out their therapist. We all know sometimes they do. And I'm glad because it creates that space to have that discussion. But as a counselor, we have to be able to sit with that, receive that feedback, not become defensive, and this is where that power dynamic comes in too. And I see this sometimes with clinicians. The client, the individual seeking services will call out a behavior, call out something. And I'm saying this because I've seen it myself. The therapist will fall back on they're dramatic. It's their own issues. It's just back to projecting that I did nothing wrong, and having that power dynamic there makes it easier, unfortunately, for clinicians to fall into that as a defense mechanism. And so really checking ourselves if we get defensive receiving feedback, how to have that conversation and have that feedback response appropriate and respectful. And so, that again, kind of as we can see for a lot of these, it's really about our own emotion management and our own work on ourselves. So again, DEI, diversity, equity, and inclusion. How do I educate myself? Whether it's just understanding concepts, what's understanding privilege, where do I fall in terms of privilege, intersectionality? So how does that look, and how am I creating a safe space? Ongoing peer support, and open to client feedback. So before I get into some Q&A here, as promised, is again, not an exhaustive list, but some resources that I wanted to provide people with. Again, earlier on the slides, I do think that implicit bias test link is a really helpful first place to start, of just checking in with ourselves. It starts with us, as we know, but these are more of kind of overarching resources. SAMHSA here, Substance Abuse Mental Health Services Association, a really long acronym. I think many clinicians are familiar with that site. It's excellent, and it is so much information, but here's a link directly to that trauma-informed care guidebook. There's also that information on plain language, and then different links, different resources if you want to get connected to other clinicians, and then also just some self-education piece. So I briefly wanted to, so a couple of things. This is the first of a series of provider webinars that we're offering. And I'm doing this one, and we'll have a few different providers, other counselors, clinicians providing some topics throughout the year. But our next topic that we're going to do, which is going to be in June, our provider relations director, Frank, who some of you also maybe know, he's actually going to be doing a webinar solely just on how to be a provider on our panel. And it can be absolutely just as appropriate as a refresher course or more information if you've been on our panel for a long time. So it's appropriate for everyone. This is a one slide overview so you can kind of see what we all offer our employees. But you'll have a much more detailed training if you want to go to that in a few months that goes over, how to be a provider, how it works to be a provider on our panel, some tips, tricks, resources, so you feel like you have everything you need to feel comfortable being on our panel. But what I wanted to talk about today was just some service summaries that we offer our employees. And one of the things I think this helps with being an affiliate on our panel is you may have a client who, as you're talking to them or working through stuff, they also have some legal stuff going on. You can refer them to us. The more you know about what we provide employees, one great thing for you is it's like, hey, this legal stressor is going on. Have you called the EAP? Because I know they do a lot more than just the counseling stuff. So I think it helps to, that kind of wraparound services, bridging care, and everything we offer is free. The other thing, of course, you would fall under this category of the therapy, but all of the organizations we contract with have a different number of sessions that they offer, and we'll go into way more detail when we do that next webinar just on sort of the affiliate provider process. But the main takeaway here is really thinking about what is the EAP, us, what do we all offer besides therapy? Some of you may know all of this, or this may be brand new to some of you. So being aware of what we offer and kind of having that bridge and having that knowledge, I think can just give you an extra resource if you're trying to think of some resources for a client with other things going on in their life, and just be familiar with us as an EAP, because I'm sure a lot of you are probably on a lot of different panels, and what do we do? So this is just kind of a starting point of all of the free services we provide. All right. So there was a question here. I'm just going to leave it on here real quick. A few questions that we have coming through, and I'll have time for a few of them. So you will get sent a certificate of attendance for this webinar today, and so that is going to be sent to you. So you will receive a certificate of completion. So anyone who attended the live webinar today will receive that. Let's see here. Okay, perfect. Let's see. So there's a longer question. I know it's always interesting because during this time you can still see my video, but I'm like leaning in to read the questions. Let me check here. All right. So there's one question that someone's talking about how they work in an organization that identifies as a Christian organization. And it's talking about how counselors, admin, board don't agree with certain components of DEI. I'm just summarizing what this person's writing. How would you recommend confronting those people and their microaggressions? I think it's interesting because there's a lot of different dynamics there of understanding that people's opinions and rights to their opinions while also speaking our truth. And if it's a privately owned organization and they are religious based, there's the systemic and the systematic dynamics. And if the systematic is in place that is not discriminating, it is very difficult to think, how do I intervene on this? How do I provide feedback if I feel like something's being said a certain way? And this could be a very long conversation past the 2 more minutes that I have. And there's a lot of specifics around that, of examples or dynamics of one's role in that organization and respecting ourselves and others' opinions, and if it's a private organization. And I think also the main thing that I think, is something that is a consideration with that goes back to how we're advertising our practice. And even as an EAP, so we can, if someone calls in and says, I am looking for specifically say, for example, a Christian counselor, we can narrow it by that. Or, if someone goes to is referred somewhere, or they call us, they're like, I went to an agency, but they were religious based, and that's just not really in line with my values. I want to go somewhere else. We can find them somewhere else based on what their preference is. So it may be something that, that specific question, totally hear what you're saying, but it may be something that could be easier to consult about one-on-one about the specifics of that dynamic. So, but I don't want to ignore anyone's questions that are coming in, but yeah, some of them are very specific and maybe easier to consult about one-on-one. All right. So again, I really appreciate everybody attending today, all of your questions. I know there's a lot of questions that came through, and I answered as many as I could with the time allowed. All of our contact info is on this last slide if you do have any questions or you need to consult one-on-one. And if if I'm not available, really any of our clinicians on staff can consult with you if you do have further questions about this. And hopefully you'll attend our next webinar all about provider information that can help with that too. And this will be on YouTube. If any of your colleagues out in the field missed it, they can at least watch it on YouTube later. You will get a certificate of completion, but if you have a session to get to, if you have other things going on, I am very much understanding of that. So I will end in a little bit. We are going to do a training. We will send out a list of our upcoming trainings because we're still finalizing the ones for the rest of the year, but we'll send those out with plenty of time to set aside time to attend those. But I know for sure the next one's going to be in June, and that's that sort of provider information one of how to be on our panel and all the resources around that. So with that, again, thank you so much for attending. I hope you have a really wonderful rest of your week. And I hope that, if you need anything else, you can contact us, but I want to let everyone get to your next appointment or session, and hopefully you have a wonderful rest of your day. Take care.